you. So I'm going to now talk a bit about what we actually did. So going on from what Verinda said, we wanted to target those patients who've got risk factors for liver disease. And we did this by two pathways. On the right is our standard of care pathway. So this is patients who would usually present to their GP with risk factors and then be referred on to secondary care. But on the left, which is more what we're going to talk about today, is the patients we saw in the community. So we saw lots of these patients in our community research van, and they all had a liver health check. The risk factors are on the left, so people who've already got a diagnosis of steatotic liver disease or fat within the liver, people who drink alcohol to harmful amounts, and have abnormal liver function tests, live with type 2 diabetes or obesity. And we did this by undergoing searches through GP records to identify those at risk. And then they were invited for an assessment. Oh. There was another slide there, but it isn't there, so I'm just going to keep talking. So at the liver health check, all patients had what's called a FibroScan, which essentially assesses their risk of having underlying liver cirrhosis or liver fibrosis. And really the main cutoff we use is 8. So if it was above 8, then they were at high risk and they were seen by us in secondary care. And if it was less than 8, they were discharged back to the GP. And as I mentioned, this was all done in our community research van. We worked with 12 practices altogether, but I'm just going to show the data from the first 7 practices first of all. So what we found is what we suspected was that people who live in areas of high socioeconomic deprivation were more likely to have a liver stiffness measurement above 8, which is what I mentioned before, those at highest risk. That's compared to those living in areas of low socioeconomic deprivation. So we already knew that there was a massive health inequalities within the patients that we were seeing. So this was already confirming our suspicions that we needed to be out in the community and finding these patients. Oh, this is the slide that was supposed to be before, so we'll skip past that. We also found that the more risk factors people have, the more at risk they were. So patients with 3 or more risk factors compared to 2 or 1 risk factor were at the greatest risk. What was really interesting as well was those who were at risk with 1 risk factor all had harmful alcohol intake. So we knew that then that harmful alcohol intake also had a greater risk compared to those other risk factors we mentioned before. So kind of what do we do with this information? So what we did is we worked closely with the data analytics team at Health Innovation Manchester, and we mapped those two things. So the left is a map of socioeconomic deprivation within Greater Manchester, and the left is a map that we created with the team that kind of weights those risk factors. So, for example, an area got the highest kind of score if they had high prevalence of harmful alcohol intake, and then lower would be if they had less number of risk factors, but also the risk factors that were associated with the lower risk. And what we did is we put these maps together to try and find areas of Greater Manchester that we perceived would probably have a higher number of patients with liver fibrosis that's been undetected. So then we went out and we tried to recruit GP practices from those areas and see patients from those areas to try and confirm our suspicions that we would detect more liver fibrosis. And this was very successful. So the right is before we started using the secure data environment and the left is after. And you can see from 9 to 15.9% of patients we reviewed had some kind of liver fibrosis. But they also had more risk factors for liver disease. And they were also from areas of higher socioeconomic deprivation. So the deprivation assessment I've used here is people who live in a third of the greatest socioeconomic deprivation areas of the country. So you could see that went up as well. So we were seeing more socioeconomic deprivation, more risk factors, and therefore more liver fibrosis. So we achieved what we set out to achieve. The other thing we did is we realised, as Verinda said, there's loads of patients in Greater Manchester, so over 1 million patients with at least 1 risk factor for liver disease. So if this is going to become in the future, which is our aspiration, and a national screening programme, it needs to be cost effective. It needs to be as streamlined as possible. So we did some work with Miriam and the team at Health Innovation Manchester to see, and Manny and the Jiva team to see if we could automate some of the process. And this was mainly around automating our clinical letters. So what we found is by automating clinical letters, we can save up to 4.2 minutes of clinician time per letter. So as you can imagine, that's a significant amount of time over, as part of your job doing an administrative task. And that can save secondary care hospitals in Greater Manchester almost £250,000, which again is a significant cost saving. So overall, we felt like we'd found another potential solution to implementing this widespread. And that's everything from my talk today. So I'll be passing you over to Gabriel from our health economics team. So